My name is Daniel Baker, and I work at the Primary Care Coalition. And it is my pleasure to officially kick off this event by introducing our host for today. We've already thanked our sponsors, Kaiser Permanente of the Mid-Atlantic, as well as Zoom for helping increase our attendee numbers as we got such an enthusiastic response from the public. But back to our host for the event today, Mary Rubino, former Deputy Editor of Health Affairs. She retired from that position in 2013, but since then, Mary has worked as an independent consulting editor to various organizations, including IBM Watson Health and George Washington University's Milken Institute of Public Health. Mary brings a wealth of knowledge about the healthcare industry and is a perfect host for today's event, Telehealth, Past, Present, and into the Future. So, without further ado, I'm going to kick it over to our host, Mary.
Good morning, everyone. Thank you for joining us today. It's a pleasure to be here with you and to see all our distinguished guests and panelists. It's going to be a fascinating discussion. We have the right people here today, so, including you. Thank you. I wanted to say that you've shared another poll for us today. So these are the results of our poll. It looks like we have a lot of healthcare providers in the group, some of whom have had access to the experience of using a telehealth as their experience, and most have been as patients. So thank you. That's great to see. Great. I wanted to give you a little background about the Primary Care Coalition so you know who our hosts are today. For over 25 years, Primary Care Coalition has worked to improve access to high-quality healthcare for vulnerable residents of Montgomery County, Maryland, and the surrounding area. PCC manages public-private partnerships that serve over 32,000 low-income children and adults who are not eligible for federal or state healthcare programs. Montgomery Cares is the program for adults, and Care for Kids is the program for children. They administer these programs and engage Montgomery County government, 6 area hospitals, 10 safety net health centers, and a network of pediatricians and practitioners, specialists in a coordinated effort to provide a continuum of care for Montgomery County's most vulnerable residents who, as I said, do not have access and are not eligible to participate in existing safety net and other programs. These are our neighbors. We want them to have health just like everyone else. So since the COVID-19 public health emergency, PCC has worked closely with these partners to coordinate information and supplies and to adjust service delivery mechanisms so that we can continue to provide safe access to healthcare. Naturally, telehealth has played a key role in this. PCC has also been thinking ahead, what to do once this pandemic is finally an afterthought, as Daniel has shared. So we're trying to make sure that during the recovery phase and afterwards, we want to ensure that the recovery reaches all levels of the community, not just the highest level who have full access, but everyone. And what we want to take advantage of this experience. If there's anything to be learned from it, there are many ways we can improve our care later on and future delivery. So we've been trying to make sure that it's equity-based. How do we apply the lessons that we're learning right now through this emergency to create a better, stronger system moving forward? Telehealth is not a new idea, but this pandemic has given us all exposure to it and all an experience of the value of technology. So now we have to find out how best to integrate this and continue to use it to improve care for all. So today's convening has been divided into 2 panels. The first one will focus primarily on how we ensure that patient populations have meaningful access to telehealth services? What are the obstacles? What are the solutions? What are the experiences that our panelists will share with us today? In the second half of the morning's event, we'll be focusing on regulatory restrictions and obstacles that can accelerate or impede our adoption and implementation of telehealth services. So before we get to the panelists, I'm very pleased to be able to introduce you to and welcome Montgomery County Councilmember Gabe Albornoz. He's the chair of the council's Health and Human Services Committee and was recently elected the vice chairman of the Montgomery County Council. Thank you for being with us.
Thank you, Mary, very much for that warm introduction. And thank you for your leadership in helping to facilitate this important discussion. And thank you, Daniel, for that soothing introduction, which is, I think, was like just, it was the perfect calming tone. I'm going to remember that. I need that moving forward. And on the heels of National Doctors Day, to all of our doctors who are in the audience, thank you for your just unbelievable leadership and service over this last year, and obviously well beyond that as well. So it really is an honor to be here representing all of my colleagues on the County Council. It has been obviously such a traumatic and disorienting and exhausting year for all of us. The constituent calls we're getting in our office are, I'm sure, consistent with the calls you're getting to your offices and clinics, which are just overwhelming and crushing need. And it has been nothing short of tragic to witness all of us, just the disparities that we all knew existed prior to the pandemic, and all of us from our various perspectives have spent our professional careers trying to address, but seeing the tragic outcomes of those disparities has been difficult and hard to process. However, there have been a number of silver linings. There have been a lot of lessons learned. I've been journaling this last year as a way to cope with a lot of this. And if I go back and I look at some of my pages, telehealth comes up often. And sharing a personal story, I've got 4 kids at home, and my 7-year-old Mateo, about 3 months ago, was horsing around with his older sister and fell, hit his head. We were worried he had a concussion, so we called the pediatrician, and we, of course, were able to do a virtual appointment. And that virtual appointment helped avoid having to visit the emergency room. But of course, we pay a little bit of extra money in our house to have a better Wi-Fi connection. Between my wife and I, we have 3 iPhones that all work pretty well and are up to date. We don't have language access issues. And so, but that visit made a significant difference, because had we had to go to the emergency room, this was in the middle of the second wave, just after the holidays, when there was a spike. And it was not a place any of us wanted to be, nor I'm sure the doctors in the emergency room wanted us to be, to help make sure that those folks that needed the most help received it. And so I've heard repeatedly from providers, from constituents, successful, positive stories of telehealth, to the point that my colleagues and I commissioned a report through an organization called the Office of Legislative Oversight, which is the think tank arm of county government and the county council. And what they found was profound. When done well, when you address those disparity issues in the digital divide, when you ensure that both the patients but the providers are well-versed and well-trained in how to access and properly use technology in a way that moves things forward, it really moves the needle significantly. And we received a report from the Office of Legislative Oversight, and then immediately after, had a work session with our friends at the Mary Center, who actually, we learned in this work session, were familiar with Zoom 5 years ago. And had been accessing it as a technology, and the strides that they have been able to make in this last year are profound. The amount of no-shows has gone down precipitously. The language access has gone up precipitously. And so there really is an opportunity for us moving forward, if we do this right, to really help close the gap in a very significant and authentic and meaningful way in those disparities in public health. And so today's session with the incredible panelists, and I am honored to be among you. You are all much smarter than I am, are here to discuss and advise and share some of those lessons learned, not only through this past year, but before that as well. And there are challenges from a regulatory standpoint, as I've come to appreciate, that cross over between the federal, state, and local level. And of course, our insurance providers are catching up and recognizing the value of this tremendous asset. Our hospitals are as well. And so we are moving in the right direction here. And that's why sessions like today are so important. And I want to close by just thanking the Primary Care Coalition. I knew of your work prior to becoming the chair of the Health and Human Services of the County Council, but I have grown to not just respect and appreciate it, but lean heavily, all of us, on your leadership. You are conveners, and today is yet another great example of creating a time and space for us to be able to gather and think and move forward in a way that is really going to make a difference. So thank you all this morning for taking the time to be with us. I hope that you can spend the majority of your day with us. I unfortunately have to bounce off to head to a couple of other sessions, but I've got members of my team on this call. And one of those members is my good friend, Beth Schuman, who is our lead on our Health and Human Services Committee. Many of you interact much more with Beth than you do with me. And I want to thank her and Linda McMillan as well from the council for their leadership too. So thank you all. Have a great session today. I look forward to the follow-up.
Thank you very much, Gabe. It's been a delight to have you here with us today and to kick us off so well. Thanks. So now I'd like to move right on to addressing the digital divide, our first panel. I'll introduce very quickly our panelists. It's Vivian Aguayo, Sophia Tripoli, and Denise Truong. Let me give you a little brief bio on each, and then we'll move into the questions. But I know we'd like to all focus on the discussion today. Vivian is a practice transformation coach with the Maryland Primary Care Program. So I believe she works very closely with physicians and practices to help them get adjusted to integrating all these technologies into their practice. That often requires some revamping of ongoing procedures and protocols. She helps over 80 primary care practices across the state deliver patient-centered advanced primary care while reducing hospital utilization and driving down healthcare costs across the state. She's played key roles in the COVID response and between testing and adoption and vaccination programs. Her education includes that she has done her undergraduate work at Spelman College in Atlanta and the Pontificia Universidad Católica Madre y Maestra in Santiago, Dominican Republic. She's currently pursuing a master's in business administration at the York St. John University. Sophia Tripoli, our other panelist here, is the Director of Health Care Innovation at FamiliesUSA. She leads FamiliesUSA's work on value initiatives that focus on reorienting the healthcare system to deliver health, and on forwarding consumer-focused policy agendas to improve healthcare delivery and payment systems. She has a master's in public health from George Washington University, and her undergraduate work was in global health at George Washington University. Also, Dr. Denise Truong is a board-certified emergency medicine physician at Kaiser Permanente Mid-Atlantic Medical Group. His organization is also the sponsor of today's panel. He is the Regional Telemedicine Mobility Director, the Northern Virginia Assistant Physician-in-Chief, and the list of his credentials is long. So I will just focus on the fact that he has spearheaded Kaiser Permanente Mid-Atlantic State's telehealth program for over 7 years, designing and implementing this portfolio of integrated telehealth and digital solutions. I think he will therefore have an ideal combination of experience in the front lines of delivering care and also working with a large organization to bring these systems into concordance across the platform. So his education includes service in the United States Air Force and work at the Veterans Affairs Medical Center in Palo Alto. He has a physician executive MBA from University of Tennessee, and as I said, board certified emergency medicine physician licensed in 9 states. So without further ado, I'll move into some discussions. One of the things we were going to start with just to define the dimensions of this challenge of the digital divide. We all know that telehealth requires, as Gabe indicated, access to software and technology to be able to have these kind of interactions like we're doing today. It requires an ability to communicate, and it requires, in a healthcare setting, some way that this is going to be, physicians are going to be reimbursed for the service. These are challenges. So I'd like to open it up to the panel to invite you to discuss some of the dimensions of this. How broad is it? What are the basic obstacles, and what are some of the more sophisticated or subtle obstacles that have continued to plague us and maybe we've overcome to date? Jump
Sure,
right.
I can jump in first. Hi, everybody. Thank you so much for having me. It's really a wonderful opportunity to be here today. Just a very quick note about Families, in case anybody is not familiar with FamiliesUSA. It's a nonprofit, nonpartisan organization fighting to ensure that everyone living in this country has access to affordable, high-quality healthcare and the good health they deserve. So thank you, Mary, for that. I think a really great question to start off the discussion. Obviously, as folks know, throughout the pandemic, families have been relying very heavily, of course, on digital services for their health needs, for education, for social needs. And of course, the digital divide really has a pretty far-reaching impact. And if those issues are not addressed, as we're going to talk about today, I think not only has the possibility of decreasing engagement with telehealth services and health services for populations that really need it most, but can actually really exacerbate some of the health disparities that we are seeing in the system play out. I think communities most affected that we're seeing right now by the digital divide include women, seniors, people with disabilities, people of color, people with low incomes, immigrants, those living in rural areas, people with low digital literacy, and of course those who are living without reliable access to internet and advanced technologies. So it's a pretty broad set of folks who are impacted by the digital divide. A couple of barriers I just wanted to point out. The first, as we've already heard, is really around broadband infrastructure, where we see about a quarter of Americans in rural areas and nearly a third in tribal lands lack broadband coverage compared to urban centers, where we're seeing about 2% or a little bit less than 2%, depending, these are nationally, of the population lacking access to broadband. So that's a pretty good chunk of folks. But even in urban centers, we also see challenges, right? New York City, for example, 50% of low-income households lack internet access. So when you start to sort of piece apart the numbers, quite a few folks struggling from having reliable access to internet, broadband services. So that's a really big barrier that we have to overcome. The second point I wanted to just flag, which was mentioned already, is of course around e-health literacy, which of course can greatly impact access to telehealth services, where we are seeing certain populations facing a number of barriers in the ability just to navigate, use the different technologies that are required to complete a successful telehealth visit. So that's another really big barrier. And the last one I just wanted to flag was really ensuring that telehealth services are meeting quality standards. I think right now we sort of have an inconsistent standards for what constitutes a high quality telehealth service or experience, which really has the potential to really burden the population at large, but even more so vulnerable populations the most. So I think we really need to think about applying a consistent quality framework to telehealth. I think one of the ways we can do that is just making sure it's integrated into our broader delivery system and payment systems, ensuring that it's a modality within a number of modalities that can be used. I'm sure others on the panel and the next panel will have thoughts about that as well. And the last thing I just wanted to say is I think, we have some options. There are a lot of options to address the digital divide. I think, it's really going to require, I think, a multi-pronged strategy that's going to recognize the various barriers that vulnerable populations are facing. But there are options on the table, including, states and health systems, organizations making investments to deploy direct support professionals, social workers, patient coordinators, community health workers, getting them into our delivery system so that they can help sort of provide that face-to-face training around e-health literacy, ensuring that patients have the tools and resources they need to successfully navigate telehealth services. And of course, we need a massive investment from government, federal government, state governments to really expand broadband and fiber optics to increase access to reliable internet.
Sophia, that was a great overview of the challenge, and I appreciate the statistics on the national level. I think that Vivian might be able to share some experiences for the local level, and Dennis, you might be able to tell us about both the challenge as a physician to actually deliver care, recognizing the challenges that Sophia has outlined for us. Who would like to jump in here? Sophia, Vivian, go ahead.
Thank you again, Mary, and all for joining today. Sophia was actually very thorough in explaining so many of the challenges that we've been facing. And I think what also has also been very front of mind, particularly from the healthcare provider perspective, has definitely been the and this came up in the MHCC telehealth policy work group in terms of, just as there are barriers with patients accessing telehealth, being able to use the systems, or even whether it's hardware or software concerns, there are actually mirror concerns on the healthcare provider side. And if you talk to any independent provider about what their telehealth experience was at the beginning of the pandemic, there were practices that they had to set it up in a hurry. Either they were using their already integrated electronic health record system, and maybe there were function capabilities that worked there, didn't work there, but they had to have a backup system for their patients that weren't familiar with one type of technology. So they may have had their EHR, Zoom as backup, and they had to have a third backup if they were going to have interpreter services on the same call. And when we talk about access, it absolutely has to carry forward that just as we want support for our patients and our community members, we also need to support our healthcare providers in making sure that when the patients are ready, the providers are ready as well, and vice versa. So I think because it is an entire ecosystem, there's just going to be, we've got to keep these conversations alive, and that's what's happening with policy recommendations. Even back to the patient side, I know throughout the pandemic, we had the Caregiver Services Corps, which was an awesome volunteer program throughout the state of Maryland. And they could do home visits and things like that for community members. But one of the very basic things that they did was show up at homebound community members' houses and showed them how to use the telehealth platforms. So there's definitely a learning curve throughout all of this, and really just all participants of the ecosystem really need to be supported throughout.
Mm-hmm. Absolutely, you really touch on that. And I think that even a large system like Kaiser, which has a long history of doing telemedicine, would probably be able to share some experiences on the same level. And as you say, the patient-facing physicians, one of my physicians had to use his personal phone as for cameras, and so there are going to be some golden things that come out of this afterwards. And I just hope we can capture them and implement them, really integrate them into the thing. Without further, Dennis, can you tell us about the experience with Kaiser?
Yeah, thank you, Mary. Thanks for both Vivian and Sophia for a great overview, because as a physician, I could not do all what you guys did right now. So thanks for doing that for me. As kind of the red carpet out. From my perspective, I always look at things, I'm an ER physician, so we tend to look at things in very simplistically. And I look at the digital divide in kind of 3 phases. There's digital divide of software, hardware, network. Sophia touched on that. digital fluency, or other words used for it was literacy, competencies. So the divide is, do you have what you need? The fluency is, do you know how to use it, right? There's another level of digital incentivization. Why would you use it? And we went through this with our physicians about 5 years ago. Our own little digital divide, where we said, well, physicians wanted to leave their work at work. They want to say, don't call my personal cell phone. I will have my computer at work, and you separated that. But I'm a fond believer that luck is when opportunity meets preparation. So 5 years ago, we prepared our physicians for anything, and no one knew COVID was coming, but we prepared them for anything in the sense that someday you're going to need to be remote. You need to be on call. You got to be able to respond quickly and communicate effectively with their partners. So we equipped all 1,500 physicians with KP laptops. All 1,500 physicians had KP iPhones, had all the bells and whistles, all the software they needed, all the data plan, all those things. And that actually accelerated the physician adoption and acceptance of technology, so that they were providing telehealth from their homes. They were providing telehealth on, they upped their broadband access to do all those things. Fast forward 5 years, COVID happens, and now we're experiencing the same thing with our patients, right? Our patients were, how do we make sure they have the access within that digital divide? Maybe they don't have, not all of them have 3 phones in the house, but maybe there's 1 phone in the house. How do you capitalize on that? How do you capitalize on the fact that maybe the family has language barriers? Maybe there's literacy with just with digital literacy in general. How do you educate them? And it's everyone's job to educate them, not just the educators that we have in our organization, but as a physician. If I have a chance with a patient, I should know how to troubleshoot some basic things. I should know how to pull an interpreter. I should know how to do all those things without having someone else have to do it for me. That sense of independence. And then the incentivization, that's on both sides. You need the physicians to continue to promote it, because the survey shows that patients that try telehealth, they try it most likely because their primary care physician actually encouraged them and offered it to them as an option. And that was huge during COVID. With all the great folks on this call, as well as our great primary care colleagues and our coalition, it was introducing the digital naive patient to a whole new way of accessing care in a safe manner. Mm-hmm. I know we all talk about policy, and I know we sat a lot of committees around policy and regulation, and it's really interesting that for 7 years everyone talks about aligning incentives, and COVID happened, and all of a sudden for us telehealth blew up 40 folds within a year. And I know many organizations saw that, because what greater incentive to align than safety and social responsibility to each other to not be spreading a disease. So it's been actually a great journey right now, and I think that's the silver lining. I think someone talked about earlier that COVID has been the catalyst for us to transform healthcare. It's been delayed for many years for whatever reasons. So yeah, this is a great time for this conversation and to discuss the digital divide. How do we get everyone the access they need in order to access telehealth?
Indeed, and these are the challenges, right? One of the study I read recently said that that there is a digital divide between those who have accessed telehealth that's based on language proficiency. So those with limited English proficiency have not been using these systems as broadly as those with English proficiency. Can anyone talk about how we have, as you mentioned, Dennis and Vivian, the challenge of bringing in technology into the encounter is literally like logistically challenging. Can the physician help you? Well, it's in that lower left screen. Just click on the video button. That one that's, and no, I don't know. My eyes aren't working, and all the things that make it very challenging. How do we keep this moving so that we can get these things going? This is what we have to work out, right? So how do we capture these things? How do we bring them in forward? And for language challenged people specifically, how do we integrate interpreter services and what is necessary? Can any of you speak on that? Vivian, perhaps, as having been an interpreter, right?
So yes, I think actually there's two sides to this. I think one, we could definitely, or there's going to, Dennis spoke on, incentives. And so there's the incentives on the provider part, incentives for the patients. We're going to need some policy incentives. We're going to need, these digital platforms that we must use in order to access telehealth. There's going to have to be incentives on that side in terms of, having your platform in more than just English, or even more than just English and Spanish. We need telehealth platforms available in Amharic, Mandarin, Cantonese. That's one very clear way in terms of how digital platforms can be more accessible, is offering them in the languages spoken by the users, by our patients. However, on the other side of the equation, what we have seen throughout the public health emergency, because this has had to, I've used this phrase a lot throughout this time period, we've had to build the plane while flying. Providers, actually, eyes have been opened up to the not just the benefits of telehealth, but what it can also mean for our patients. So now we're having telehealth encounters, and you can have the patient's adult daughter on the same call, where not necessarily she would have been able to make it to the in-office medical visit. Or they're able to make the call from home. So there's support for cultural support. Sometimes it's then, younger family members clicking the button or tapping the right screen or what have you. So the more accessible we make telehealth, either language or just usability, and and then also culturally, for some cultures, health is communal, it is familial. So the more that we can make telehealth fit people, I think that's how we'll be able to access the hard to reach, and actually offer to all patients who need it.
Mm-hmm. Go ahead, then. Yeah.
I'll just add in, well, I'm not sure if Dennis was going to jump in, but I'll just add in, I completely agree with everything that Vivian said. I think absolutely you're going to need some policy pushes here, right? Some regulatory pushes, I think is a help. But I do think there's also opportunity for, healthcare organizations and systems, for independent providers to leverage what they're already doing in delivery system and payment reform, and to be thinking about payment incentives and ways that you can financially incentivize, or for making sure that you have access to language interpreters and language services. So I think that's another tool that we have at our disposal right now, that we can, many folks are already doing that or starting to do that, and we can keep doing more of that.
Yeah, and if I can just get more of a execution side of how do we execute this, I tend to think about delivering of telehealth as, I have this fascination with Amazon. So it's this big, like, first mile, middle mile, last mile, and last minute of delivery, right, from supply chain. First mile in our organization, we think about as your providers. Your first mile is the people providing care. The middle mile is the technology. The last mile is the patient, right? And that the last minute or the last, whatever you call it, the last couple feet is the white glove service. How do you really, roll the red carpet out for them to get back onto a telehealth visit? So the first mile, you really have to, educate your providers and incentivize them. And that's the two parts of educating them is, you got to know how to use your equipment. And everybody wants it to be FaceTime simple. It's not always going to be FaceTime simple. Especially as you integrate technology and make it more secure, it's not going to be as simple as the FaceTime, but it's a benefit to everyone that security is at its utmost importance, and that it's that we still try to integrate as much as possible. That's where the technology side is in the middle. And of course, on the patient side, we've got to educate the patient, incentivize them to use this technology. And then the last mile is really about understanding the cultural differences, the language differences, all those things. Just one example, we did it when we rolled out telehealth 7, 8 years ago. Every technology that we brought in needs to be integrated with our EMR, right? So a perfect example is, like, I think one of you had the example where you're on a telehealth visit. I can pull in an interpreter. I don't have to call a separate line. It's a button I press, and it brings an interpreter, 120 different languages, right? I can bring in a American Sign Language person into the visit. I can bring a family member from Seattle, which I do. I just did that last night. I can bring in family members and build that community feel for the patient. So wherever they're at, whoever they need to know who helps them with the medication or help them understand the instructions needs to be on that call. To be able to do that, you got to integrate first. So that's like beginning with the end in mind has been kind of the execution approach for Kaiser Permanente. And that's helped us because we watched our language line on a video visit grow 4,000% within the first couple months of COVID, which for me, that means there was a divide before that it got addressed in some way, and really put a spotlight on that so that we're continuing to integrate better and add more features and functionalities around those things to help certain groups of patients get on and kind of roll that red carpet on for that last minute for them of the delivery.
Excellent. And I think when you describe the challenges and how long the rollout has been for Kaiser, this is sort of like preparedness work. I used to work in disaster relief. Preparedness is never popular until after a disaster. And happily, we haven't had this, and how are we going to learn from it? But Dennis, you've had the experience of building the prepared system, and then there it was, ready. And as you said, it grew. And Vivian, you've been working with these providers who many times, as we all know, the ecosystem has changed radically over the last several years for many physician practices. They are now not able to work solo as well. It's what they still are, and there's integration and value-based care and all sorts of terms and concepts that are challenging to many of these physicians, and they just don't have the resources or personal bandwidth sometimes to provide to adopt technology, which one to do. Even when the EHRs were rolled out, there was no standard that they could say, okay, this is what I have to get. And now we're in that place again, right? When you mention having all the kinds of language abilities that we should have, platforms available in multiple languages, not just so you can pull in an interpreter, but so that the patient can initially interact with the platform in their language. We're a long way from that, aren't we?
Well, I was going to say, Kaiser Permanente is so impressive, and it's a national organization. And I think on the opposite end of the spectrum are my little, one provider practices, or sometimes it's a husband-wife, partnership that manages this, small practice on the Eastern Shore. So in terms of connectivity, that's not necessarily there. Their buying power, or even the weight they have to throw around to ask for, better accessibility, or, concessions with their EHR or modifications, it's not the same experience. And so I do feel that we're at a place where here's this opportunity, and we're seeing this right now with the Maryland Primary Care Program and their primary care vaccine rollout, where our primary care providers have these relationships with patients. There are patients that said they were not going to get the COVID vaccine until their doctor had it, and they could go to their doctor's office and get it. And so in that same way, empowering small practices and providers, and resourcing them with what they need so that they can leverage their intimate relationships that they have with their patient populations. That will also be the way that we make telehealth accessible to all people.
Yeah, it's a big challenge. I think this conversation just illuminates that we have the right people here, from the Sophia with the broad 30,000 feet level. Here's the scope of the problem. And then these lovely examples of from the trenches at a broad institutional basis, and then the private care, little independent practices. And all of these are part of our network of care in the United States. And the patients we're talking about now are people who are even outside of these levels of networks, right? The patients that Primary Care Coalition serves are patients who don't have a regular provider in a lot of occasions, and they are coming to some of these, interacting with some healthcare providers in ways that are novel and naive, to use that phrase. They're first timers sometimes, they don't have this system. So these challenges are really broad. And I wondered if anybody would like to share any particular solutions that they have found that might work, that would be valuable, or that we could share with our participants.
Yeah, if I may jump in first, so I think solution-wise, from a telehealth perspective, and from providing that last mile, you have to give them a lot of options. I think that's the biggest thing. I think we're talking about a lot of telehealth here, about video visits, right? Telephone visits is in that synchronous spectrum, and there's also asynchronous. There's texting. You can text with patients. You can do secure messaging, email. We have e-visits. Those questionnaires, stuff like that. Be able to use all the Legos in your box, I guess, as you say, has been kind of a savior for us, because that's the way you reach folks in their different parts of their digital divide, right? You may not be able to get on video because you don't have strong enough broadband. I can switch you over to a chat. I can switch you over to a text. Or I can just text you. That's the only thing you have. You don't have a smartphone, but you can text on one of your older phones. Being able to use all that has been part of our education of our providers. You don't just have one trick in your pocket. You need to know how to use all your equipment that we gave you 5 years ago, and you need to know how to pivot between one or the other based on what the needs of your patient is. And that may change. Man, sometimes you've been on a video visit? I had patients on a video visit where they're somewhere not home, so they were unfamiliar with their internet access at that moment, and you're somewhere where you're actually in a rural area and you don't have really good internet access. Let's switch you over to phone, or let's chat. Mm-hmm. But different people have different circumstances depending on where they are and what they're doing. So I think that's where providing options allows us as providers not to just give up really quickly, but make sure that we are continuing to use the right option for the right patients.
I think the comments you've made are great segues to our next session, because payment for these services, regulatory restrictions, the whole HIPAA privacy concerns, are those phone calls protected? Are they safe? How do you capture this data then for the electronic health record, so you have a continuum of care? These are all challenges that I think we'll touch on in our next session. But as we've reached the 10:15 mark and plus, I suspect that my Daniel's going to want me to wrap this up, and he'll launch his next poll. And I will thank our first panelists and say thank you very much, Vivian, Sophia, and Dennis. All of you, it's been a wonderful privilege to hear your insights and share them with our panelists and our group and attendees today. Thank you very much.
Thank you.
Just real quick before we make the full transition, just going to let everyone know I will be launching a quick poll, but we do have a question from the audience. I wanted to see we can just get that in. So one question for anyone on the Digital Divide panel. How do you ensure privacy and deal with HIPAA requirements and still be flexible for patients? I want to see if anyone had any experience with that.
Dennis, I'm going to throw it to you if I can.
Okay, yeah, I think that's where the integration is important. I think when we integrate the electronic medical record system, we have a technology risk office that really assesses the vendor, assesses the platform, and then assesses the integration points to make sure that you are following HIPAA. And that's when I talk about texting and talk about calling. That's all done for us. It's all done on HIPAA compliant platforms. So, if I'm with a patient, I said, well, I'm going to send them a text. It doesn't show up like an iMessage on an iPhone. It shows up as an encrypted link. and then you click on the link and it opens up in a secure browser. So that's what I was talking about security. So I think that's really important. I think during COVID, even in our organization, we tend to get a little bit lax about security and privacy and those things because it's COVID. I mean, it's disaster time, like Mary was saying. When you're in disaster mode, you do what you got to do. But I think that's where groups like these are so important, that we reset our standards, we calibrate as we're exiting COVID and saying, well, what's next? How do we ensure standards that we upheld so passionately before COVID?
I could just add one thing to that very quickly. I mean, it's such an important question. It's such a huge question. You probably have a whole separate panel just on this. But I completely agree with what Dennis said. And I would also say, and this sort of ties into the last question, Mary, you asked about solutions, is I think part of this in terms of, you have to uphold, of course, the regulatory framework of HIPAA, especially as we come out of the public health emergency over the next year plus. But in terms of the flexibility for patients, part of that is empowering patients with tools and knowledge, and which many folks are already doing, right? But figuring out the care delivery mechanisms, the sort of provider, the team-based care approaches that you need to make sure you have CHWs on your care team, bring in peer supports, bring in direct support professionals, social workers, folks who can interface directly with patients, help them navigate systems, including like digital systems, the telehealth systems, help do some education around, well, what are your privacy concerns? You're going to click on that link. Well, what does that mean? You're going to download your data through this app. Now with opened up APIs, what does that mean for you? What are you getting access to? What do you need to be concerned about? I think that's a whole realm that we haven't quite maximized the opportunity there to make sure patients are empowered with the tools and information they need to really be able to successfully to navigate. And it's, I think, a challenging proposition to put the onus just on consumers without those tools and support to think that they're going to be able to really understand the impacts of what's happening to their data and where's it going and who's owning it and the like.
I will just say, we're coming out of an experiment, right? This has been one collective experiment of a public health emergency. We haven't had our last pandemic was 100 years ago. So I think it would only make sense for us to assess the positives, assess the deltas, figure out what we can take away from it, and what could have been improved and what was actually working well. And I think when it comes to HIPAA, there were some constraints, and I think they're going to jump into this in the parity conversation. There were constraints prior to COVID. And so I think regulations are important. They're there for a reason. And so we need to take what we've learned from this response to the public health emergency and apply it to protecting our patients while also serving them the best.
Well said, well said. Daniel, did you want to launch the poll?
Yeah. I would launch a couple polls for everyone in our audience, and just to let you know, we do see the questions on the Q&A just in the, to respect everyone's time. What we can do if we're not able to answer any of your questions live, what we'll do, we are going to be sending out a couple of emails follow-up after this, so we can get our panelists to collect answers via email in a written way. But as I say that, and as we kind of transition over to the next part of this event, I wanted to launch one poll on people's experience with telehealth as we do that. So that's going to show up. So if you just take a moment to fill that out, feel free, let us know about, again, your experiences with this. And as I mentioned, if we're not able to get to questions live today, that's okay. What we will do, we will send questions to our panelists, and over the next week or two, we can collect answers and share some of the information to continue the conversation. Because as our wonderful panelists have said, this is a learning process. It's very much ongoing, and it's something where telehealth today might look very different from telehealth that comes out of this in a few months' time as we continue to kind of progress and make changes along the way. So there's this one poll, and as people are filling that out, again, wanted to say thank you very much to Dr. Dennis Truong, Vivian Aguayo, and Sophia Tripoli very much for your answers, for your time for this first portion. If you are able to stay with us for the next one, feel free. That's all right. And obviously, Mary, thank you so much for continuing to steer the ship. So I'll just keep this one up for just a moment, and there'll be another one right before we head into the next one. And, you know, look at that. We still have everyone who has been on the call from the beginning. So everyone's here for the whole event. It's very good to see the engagement from everyone.
Mhm.
So just give this one just a couple more seconds. Looks like a lot of people have had experience using telehealth on their smartphone, which is no surprise. And again, we're going to use this information as well as some of the questions that have been populating on the Q&A as well as the chat to further the conversation with our panelists and make sure to get everyone who is in attendance and who signed up for this event as much information as possible. So I'm going to end that first one. And as we can see, most people have used their smartphone for a telehealth visit, and also quite a few folks have had to access telehealth in another language, and we see some issues that come along with telehealth in the first place. So we're going to do one more real quick as we again transition into our next section on payment parity. This one much shorter to fill out, and then we'll get right to our panelists and should be wrapping up close to 11. So this next poll has just launched. I'll give that just about 1 minute. Again, much easier to fill out than maybe the others. And thank you all so much for your engagement today. Thanks again to Kaiser Permanente of the Mid-Atlantic for being one of our sponsors, as well as Zoom. It's nice that we're all able to get together and share all of this knowledge, hear the expertise from our wonderful panelists. Even though we obviously can't be here in person, hopefully in the future, in the not too distant future, we can do this again in person, whether it's at PCC or another event in the area.
Meanwhile, I would say direct people to Dr. Truong has kindly answered one of the questions from one of our attendees about telehealth resources. And a participant asked if there was a telehealth regulation website that they could recommend. I think, and he has recommended that the Mid-Atlantic Telehealth Resource Center is a great one. And I think that our next panel will also might have some suggestions, as they will be dealing with the regulatory and reimbursement aspects of telehealth delivery. So are we ready to move on to that, Daniel?
We are.
Okay.
And thank you again for taking part of the poll. And Mary and our next group of panelists, you're up.
All right. So as everyone can see, I think people have perceptions about the rates that telehealth should be reimbursed for, and what their characteristics are. You can see that most of our people are patients only, but there's a fair representation of others too, and this idea of resources. So our next session is called Payment Parity and Coverage Requirements and Reimbursement. And we have, again, three wonderful, very talented and experienced panelists to introduce today. Denise Walsh, who is a certified professional coder and certified HIPAA security professional. I will introduce them each in a minute. Robyn Elliott, who is a partner with Public Policy Partners, and Jennifer Witten, Vice President of Government Affairs for the Maryland Hospital Association. So Denise, as I said, a professional coder and a consultant, and she has worked with a range of clients to create and implement compliance plans, design and implement charge capture and coding systems that maximize reimbursements for providers. She is a BS degree in Allied Medicine from Ohio State and is a member of the American Academy of Professional Coders. Thanks for being with us, Denise.
Thank you.
Robyn Elliott is a partner with Public Policy Partners, where she represents community health centers, nursing organizations, and women's health issues. She's an expert in the state budget process. That's quite a coup. Regulatory reform and healthcare financing. Before joining Public Policy Partners, she had been with the Maryland Department of Health. Her education is, she has a master's in healthcare administration with a concentration in finance from University of North Carolina, Chapel Hill. Jennifer Witten, finally, is the Vice President of Government Affairs for the Maryland Hospital Association. She leads the efforts of the association in representing Maryland's hospitals before state and federal legislative and regulatory bodies. She provides guidance to the leadership and defines, implements, and monitors overarching association goals while establishing annual legislative and regulatory advocacy priorities. She has also worked as a nurse and an emergency care provider and an EMT, right? So terrific range of experience that you each bring to these positions and to our panel today. Thank you for being here. It's really a treat. If you were here in the earlier part of our session, you heard many of the questions that sort of arose. We have challenges about reimbursement, challenges about regulations. Can we talk to these people using this device? Is it safe? Is it compliant? What about, is it chargeable? Can we be reimbursed for this? And can we capture it and record it in the patient healthcare records so that it is not lost and it becomes part of what we really know what they were experiencing at this time over time? Who would like to jump in right here to give us an overview of this challenge?
I'll start. So thank you very much, Mary, and thank you everyone for being here today. And I just want to say that the first session was so informative and everyone was just great. So I really appreciate being a part of this panel. And I want to reiterate what Vivian said from a practice perspective. There were many struggles as COVID hit. And so, you know, from the, of course, as COVID hit, the practices are looking, providers are looking, you know, how do they render services the best way to their practices? And of course, there was struggling with, you know, payer guidelines as well as platform issues. Smaller practices, again, struggled more so than our larger practices. Some of the larger practices were already set up, you know, with telehealth services. Some of them were incorporated within their EMR. So it was those small, as you say, mom and pop practices, maybe over on the Eastern Shore where, you know, their patient population was primarily Medicare based. So you're talking elderly patients in an area with not great connectivity. And so not only are you struggling from the provider side to provide these services, you're struggling from the patient side to be able to get that connectivity. Not only was the connectivity available, but explaining to these patients, you know, how do you log on? In the beginning, I remember talking to one provider and say, you know, I spent 20 minutes just going step by step with this couple to, you know, implement the FaceTime. So there are a lot of struggles. And, you know, as COVID hit, you know, the payers were primarily on board with shifting to telehealth services. But, you know, they expanded their guidelines, which is a good thing. They expanded their guidelines, they expanded coverage of what telehealth services were. But there were frequent, and I mean frequent, policy changes the first several months of COVID. I think by maybe mid-May, they had stabilized, but there were still a lot of differences, and it was very difficult for practices. And I'm looking at this, you know, from a practice perspective on, you know, how practices will treat their patients and not only be able to care for them, but be able to be reimbursed for their services. So as these policy changes were frequently changing, you know, it was up to the practice to stay up to date with that. So, you know, undoubtedly, I'm sure that the practices had claim issues, denials, because there were a lot of, like as I said, guideline changes, policy changes on how these services were to be billed. So, and when I mean billed, you know, what was your place of service? You know, you were looking at place of service, whether it be considered in the office, or were you using telehealth as your place of service? Some practices, or excuse me, some payers wanted specific modifiers. Other payers wanted, would cover services that others didn't. So there was very little uniformity in the payer guidelines and the regulations. So it was a struggle for most practices, you know, in the beginning of COVID, to make sure that they were performing these services, rendering these services, and then, you know, as well as getting reimbursed for these services.
Mm-hmm. Absolutely challenging, and these are the one I know some providers who said, I just want to give them, I can't say no to my patients. So even though they weren't set up properly to be reimbursed, or the reimbursement was so modest for some telehealth visits that it was hardly worth their time to come into the office or set up their system, they are dedicated, they want to deliver care. So these are challenges too. I think that there are some, the regulators and the regulatory community are not unaware of these challenges. And I think our other panelists have been engaged in some activities to sort of help ease this along. Robyn or Jennifer, which one of you would like to start to tell us about some of the regulatory community that improvements, adjustments, negotiations that are ongoing that might lead to enable us to capture these lessons learned and move forward with a better approach?
Thanks, Mary, and thank you everyone for hosting this. It's such a pleasure to be here with everyone and hearing from so many of our colleagues across the state about their experience. And I'll start off, Robyn, and then turn to you. You and I work on a lot of these issues together, so I always appreciate your perspective. I just want to emphasize what Denise was sharing, and that the complexity of what we experienced through the pandemic. You know, I think, Mary, you said it at the start of the session, really, is that telehealth has been around for truly a very long time, but there were so many policies and barriers in place that it really did not allow providers and patients really to fully leverage the kind of different technologies, the different platforms, the different uses. And I guess the silver lining, as we've all discussed, is the pandemic really accelerated the ability for us to really fully actualize how these technologies can be used, but the complexities of the guidance. And so just to emphasize that, you know, we have guidance coming from the federal government, so CMS, and those institutions and ONC issuing guidance around HIPAA compliance, some of the waivers in terms of using different platforms, being able to deliver services and not being restricted on where an originating site is or a distant site, meaning as a provider, you would have some flexibility on where you were to deliver those services. As many of you probably know who've joined us today, CMS has been pretty prescriptive over the years around limiting whether it be geographic consideration or where a patient or provider is located. And so we saw a lot of movement and flexibility in that space. And then what we saw was how the state responded. And so thinking about some of the other payers in this space. So how did Governor Hogan and the Maryland Department of Health, and many of the regulatory agencies, then how did they take some of those flexibility and adopt regulations? So what we saw was a number of executive orders that allowed flexibility in terms of licensure. I've seen some questions on licensure, consideration for coverage. I think that's really important for folks to understand. It's one thing to have a service covered under a health benefit plan or covered by the state, but it's another thing to actually reimburse a provider who delivers those services. And so there was policy set in those spaces. Then we had our commercial payers that were, as Denise said, sort of moving along the spectrum and paying to some degree, reimbursing providers for the services. But it was very complex and it was not standard across all those payers. And so we saw a lot of different levels and different policies in terms of their approach. So trying to make sense of that real time. And I think it's right, Mary, in that providers just wanted to respond to their patients and provide the care. And so for the first time, we saw that audio only is an allowable service. One could argue whether or not it's telehealth, but that's the way we've captured it. And we were able to use other technology platforms. And so we're thinking about how we take those policies, how does that guide the work we do? Then to Vivian's work, and how do you work with practices depending on size and capability and actually implement that into your process? Because it's not a switch. You have to make sure you've got staff who can ask the right questions, set up the right appointments. There's an infrastructure involved there. And I think that goes to the poll that was asked earlier, is that we need to recognize that just because we're delivering care through a technology doesn't mean we don't need the infrastructure in place to like facilitate that. And then working with patients where there are. So, really consumer choice, I think, and I know Robyn will speak about this, is that's been a huge focus for us here as we work through regulations, as we work through the General Assembly here in Maryland and looking at legislation. We really want to be able to allow consumer choice. We know by a number of surveys that at least our members have done that a number of patients want to continue with telehealth. So maybe not at the 80% threshold we've seen during the pandemic, but 40, 50% of those same patients want to continue that service. So ensuring we've got patient consumer choice, and then making sure we're providing the resources to the providers at any level that they're coming to deliver that care. And so I'm going to turn to Robyn here, and she can speak to some of the work that we've been doing here during the General Assembly to preserve some of these flexibilities and to preserve some of the policies that were issued so we can continue this work and create some, I think, equity for providers and patients accessing those services. So Robyn, I'll turn to you now. I know you've got a lot of good thoughts to share with everyone.
Good morning, and thank you for having me today. We've done such tremendous work in Maryland, and really as a result of there being so many providers and consumer groups interested in Maryland moving forward with telehealth, even pre-pandemic. I wanted to mention some of the things that are happening in our state in terms of the legislative and regulatory process. And really, this work started a long time ago, and wanted to mention in last year, and this legislation was put in pre-pandemic, but Maryland ended up, the General Assembly adopted a bill that makes it clear that any licensed or certified healthcare provider, whether it's an occupational therapist, a dentist, a primary care provider, can provide telehealth and use all those Legos in the Lego box, whether it is asynchronous or a video chat. And so that happened in 2020, and that's really lays the groundwork for us moving forward beyond the pandemic. And just wanted to mention, Maryland's now considered a model state because of that legislation. So fast forward to the 2021 session, and we are 11 days away from the end, not that we're counting, but the focus has been on how do we keep the momentum going? We've had a lot of flexibility, as Denise and Jennifer and some of the prior panelists talked about, in terms of payment. How do we keep that going? So there is legislation being considered, and it's looking very hopeful. House Bill 123, which is Delegate Pena-Melnick, and its companion in the Senate, Senate Bill 3, Senator Melanie Griffith. And it's looking at guaranteeing payment parity for two types of telehealth services, the audio visual and then the audio only. And it looks like that is going to go through. And we will have a guarantee for a couple of years while everyone pulls together and studies it under the Maryland Healthcare Commission. And I know some of my panelists may be able to address one of the key components in that legislation is the audio only piece. And just to circle back, that is such an equity issue, whether we're talking about people in rural areas, people without access to broadband because they can't afford it, or individuals who have trouble accessing technology or managing it. That audio only option has been such a critical factor in maintaining people's health during the pandemic.
Well, certainly, as you mentioned, sorry, Denise.
No, go ahead, go ahead.
I'm thinking of my elderly in-laws who are able to, one of them is able to use a smartphone, but his vision is failing. It's harder and harder to see the little cursor. But the telephone remains a tool that they can use. And why not, right? If they can tell me about their symptoms, can't they tell a provider? Yes. I don't know if the provider has quite as long to listen. So, but these challenges of the hurdle that it really gets down to, you have a provider who wants to give the care, they need to be able to sustain themselves so they can, and the regulators, the people who come up with the rules and the laws that make it so, are the Captain Picards of the world that say, make it so. And thank you both for working at the legislative level to help advance these things so that we can more broadly and more permanently, ideally, make these things accessible to everyone. Denise, let me go back to you now.
Yeah, so I was going to just kind of hit on that point about audio only, and I agree with both Jennifer and Robyn immensely, the need for this. And so, you know, as you look at the different payer policies and regulations, you know, Medicare, Medicaid, the commercial payers, there are vast differences on who covers audio only services. And so, you know, Medicare does not cover audio only E&Ms, but they do cover telephone services. So, and they are reimbursing those telephone services at the same rate as E&Ms. So again, it is an issue of the practices have to understand the guidelines, have to understand the differences, and how to bill basically that same service.
Can I interrupt you for a second just to explain what is the E&M?
Oh, I'm so sorry. An evaluation and management service. So an E&M, an evaluation management service, is an office visit. It is, you know, and I apologize for that, is your visit with the doctor, whether you are in person, you know, that is the office visit. So, and I will say that one of the good things is, so the American Medical Association every year updates their guidelines for coding and procedures within the medical community. And so there was a huge update this year as of January 1st, and they updated the guidelines for evaluation and management services. This is the services that you have with your doctor in the doctor's offices. And so how your doctor determines the level of your visit, you know, it was typically a level 1 to level 5 visit. And there were 3 components that were used to determine the visit: history, exam, medical decision-making. And medical decision-making is, you know, the doctor's process on how he treats you. It's the management of your condition. It is the treatments, the risks that are involved, anything that is prescribed, you know, testing, all of that is considered medical decision-making. So as of January 1st, the AMA has said that we are basing the level of your office visits on medical decision-making only. So this really lends to audio-only visits, because you no longer have to do that hands-on exam to look at the level of the visit. You are just looking at the management of that encounter. So you can manage a patient's encounter. You can get their history. You can, you know, understand the medical necessity of that visit. You can get all of the patient information, and then do your the management of that, the medical decision making, all audio. So, you know, it really does lend to helping providers now bill for telehealth services, not even just audio, but audio-visual, because even with audio-visual, you're not going to be doing the hands-on exam. But these new guidelines really do lend to help providers bill more appropriately for their telehealth services, and that includes, you know, audio. So, you know, I just want to reiterate that the differences here with the audio coverage. You know, like I said, some payers will cover it, some commercial payers, although Medicare doesn't cover audio only evaluation and management services, they cover telephone services. So, you know, you really need, as a practice, as a physician, need to understand what those differences are and how to bill accordingly.
Right. And I imagine that physicians then need all sorts of people who help them decide on that. So
Yeah.
that's where consultants come in, I guess. The other thing people were someone asked about recognizing that we need incentives to help physicians and regulators implement these innovations and regularize them and monetize them. What are they asked what kind of challenges are available for, what kind of regulatory or payment incentives can help overcome the challenges faced by the population that face digital divide? And as sort of including affordability or older patients and who are less comfortable or competent with the technology. And I imagine you all would have some suggestions there. I was thinking initially, just sort of thinking about almost like doulas for individual patients, or some kind of having when we had the Affordable Care Act and we had engagement officers, people who would go out into the community to help people learn how to sign up for the Affordable Care Act and for the exchanges and all those things. And that was a funded position in various states. Are there activities or efforts to help bring that kind of care, access, training or help to the people at this point, or to physicians actually to help them that way, to improve access? You're nodding, Robyn, so I wondered if you had a.
Well, I think that's a really great question. It's consumer literacy, right. And how do we support that? Because I think some of the underlying incentives of telehealth in terms of convenience and being able to empower yourself to maintain your health, those are huge incentives. Mm-hmm. And how do we help people do that? I mean, it's one of the reasons why payment parity is so important. We know that a lot of the sort of work to support patients comes from the provider. So I think there's this idea that a telephone call or a video chat is, because it's not in a physical space, that it's somehow less infrastructure intensive. We actually know now that in some cases it's more infrastructure intensive. I heard the discussion about, the provider's office spending 20 minutes to help someone get up on the app. That's a really common experience. And so making sure that part of it is making sure that we're paying providers sufficiently so that they can continue to offer that support, and then looking at what that means. I know someone mentioned earlier a decrease in no-show rates. I think that is a huge way that we can measure whether or not our telehealth system is working for both providers and consumers. Mm-hmm. Mm-hmm.
Yeah, Mary, if I may add, and I agree with my colleague Robyn on that. I think this makes me think of some of the value-based models that we've seen, and so appreciate that the coalition has a number of probably physicians that are engaged throughout the communities, but know that they work with a number of other providers, to your point, Mary, whether that's community health workers or navigators. Also working with our EMS providers in our community. Sometimes our public safety members are the trusted source within a community and have access to community members. So know there's a number of models that are being tested right now. As many of you know, Maryland's kind of unique in that we have this approved model through CMMI that allows us to really innovate on getting payment for different ways of delivering care through our total cost of care model. And know there's a number of initiatives underway right now where we're really working in teams. Vivian's part of some of that work as well in creating some of those incentives for those other providers. And so again, how they integrate telehealth into that. And so if it's connecting a patient with primary care access, but having, say, an EMT or a community health worker in the community who can be that sort of person to help them navigate, whether that's connecting with the technology or identifying whether in fact they need to be seen in person. You know, we're still going to need that that level of, I think, a touch point. I think we can't lose sight of that human element. I also think that, as Robyn said, this is about consumer literacy. So making sure that we're engaging with organizations that work with individuals in the community. And we saw that during the General Assembly, there were over 50 organizations engaged in just the legislative debates. And many of them were consumer organizations, whether that was AARP, the American Heart Association, the AHACS, the Rural Health Association, a number of organizations that are working with community members and trying to identify how they need to be served, because I think they're unique. We can't apply, I think, one model in one community and that it will work in another community. We have a number of members who applied for grants through FCC and some other sources, and were able to get iPads, for example. So this was an opportunity where they were able to share some technology and were able to work with families to ensure that they had that access to deliver care in person. So I think we're going to be looking for more of these opportunities as we move forward. Once we sort of have a sense of what the policy environment's going to support, then how do we look at the resources needed, and most importantly, what do consumers need, again, to ensure we have access to care.
Mm-hmm. That's great. You know, there's always a flip side to all of these advances. One question someone asked was, how do you, if we become very effective with the telehealth approach, how do we avoid having payers decide, you know, that's a low cost way, once you've got it set up, it's a lower cost way to deliver care. How do we make sure that patients are getting care in the best setting they need to, and they're not being driven to do telehealth instead of coming to the office? Is that a legitimate fear, or is that just sort of looking for trouble?
That's a good question, Mary. I'll take the first approach to this, and we'll offer it up to my colleagues for comments. You know, I think what we're finding, at least from the data that we're gathering from patient experience, and I can speak to mostly from the hospital's perspective, but know that many of my colleagues represent work with other organizations and providers from varied backgrounds and in the community. But what we're finding is that, you know, I think patients still want to retain that ability to have the option for in-person services. We are seeing that slowly return back to normal, especially as we see the vaccine roll out. But for some services, there was such a value in being able to access those services via telehealth that consumers are indicating they want to retain that ability. And I think in the space of primary care and working with individuals with chronic disease management, I think there's great value in that, but we're still going to need to have patients come in. We're still going to need to do laboratory work. We're still going to need some of those traditional interventions. I think we saw a lot of value in behavioral health services and being able to deliver those services through telehealth. So again, I think it's balancing the approach with consumer choice and patient and provider discretion. At the end of the day, we are putting a lot of trust in the providers to determine the best way. And we need to preserve that. So through all the policies we develop, we need to preserve that. But I think we just want to allow that flexibility. We will likely see innovators coming into the market. I'm thinking of Amazon in particular, Mary, so where they're really disrupting the market, quite frankly, and forcing a lot of consumers to access care via different technologies. That may not be a bad thing, but we need to preserve the access point with our primary care providers and our providers in the community. So it's really sort of, to me, a balance, and we don't want to create a two-tiered healthcare system in the state. I think we need to really think about equity. So that's going to be really key as we think about policies moving forward. So I'm sure Denise and Robyn might have some thoughts on this as well.
Well, I couldn't agree with you more, Jennifer. And I really do think, you do have to leave it up to the providers, to the clinicians to decide, which those patients that need to be seen, that a telehealth visit isn't sufficient. And I would hate to think that providers are doing telehealth visits on patients when they really should be seeing them in office. In fact, many encounter notes that I've seen recently is if a provider has set up a telehealth encounter and felt that the patient needed to be seen, will request for that patient to come into the office. But as a telehealth for that elderly population, for that chronic condition, those stable chronic conditions, telehealth services are so beneficial. I mean, I can't imagine them going away. I mean, as an example, my 94-year-old mother-in-law who is in, excellent health, but to go, so she goes to see her provider every 3-6 months, for refills of medications to see how she's doing. For her to go into the office, it's somebody else is going with her. It is a real, event. So, to be able to pull up her iPad, which she does have and use, and to do her, telehealth visit to tell her primary care how she's doing, get her refill of medications, that visit lasts 15 minutes instead of, a half a day ordeal, that involves, multiple people in the family. So, I do feel that this is, it is a benefit to the patients. I think some patients may have felt initially that it was a difficult, to arrange, to get set up, the connectivity. But I think once that it was established, I think that, patients as well as providers feel that, it's a benefit to plus. It's not the end all be all. You still will need to have inpatient, in office encounters. We'll never get away with that. And, so I think it works hand in hand with our in-office. I mean, to use them both together and, to see those patients who can be seen by telehealth and seen so appropriately and adequately and given quality health care. And then for those that need to be brought into the office. So it does go hand in hand, and hopefully our providers will continue to work that way.
Right. So I thank you very much. That was spot on, I'd say. There was one question from the audience that I did want to address, and it really invites us all to sort of continue to clamor for change, to make sure all the voices in the community are heard. They ask, how can we as providers and advocates and regulators and lobbyists and all the rest work with the technology designers to keep in mind and design their platforms in ways that consider and acknowledge the barriers and equity issues faced by some populations. One example comes to mind is I know people in my community who don't have access to the internet services often use the public library for their email and the rest of the things. For all sorts of services, but during the pandemic that was closed too, and you couldn't even do that. So how do we provide going forward, methods where we could set up, where there are other resources where people can get access when they don't have it on their own? Are there going to be kiosks somewhere that you can just public access Wi-Fi? I don't know. But, and how do we continue to work with technology and inform technology and the technology designers? So I don't know if there's a simple answer to any of that, but if any one of you would like to jump in, I welcome it.
I think that's just it. It's not a simple answer, and it would be difficult to try to give you one, to be honest with you. I think that I have seen changes with the different platforms. They are making them more user-friendly. They are making them more accessible. You know, the platforms, apps that can be downloaded, not just using your FaceTime, but apps that can be downloaded to your phone. So, you know, using those kiosks, as you would say, are going to the public library for this, then poses your privacy issues. So there are so many things to consider here. And I said, I don't really think that there is an easy, simple answer. We have to take all of that into consideration. But I do see, you know, over the past year, there have been a lot of small changes, you know, and as we work towards this, and whether it's just getting a HIPAA compliant platform, you know, that's on your, through your EMR, and that patients, you know, apps that patients can download, whether you are doing it through your patient portals to be, you know, more compliant. Yet again, I wish I had an answer. I really do. I wish I had
we might all be out of work if we had all the answers. But I really thank you all. I think unless someone else has something else to add to that, I'll say thank you each and everyone for joining, for sharing, and for continuing your good work in the trenches with the regulators, with the caregivers, with the coders, with the providers. Thank you all very much, and thank you for joining us today at the Primary Care Coalition's convening on telehealth. It's been a really delightful morning with you. Thank you very much.
Thank you. Thank you.
Thank you very much, Mary, Robyn, Denise, Jennifer, and our panelists from earlier as well. Thanks so much to our sponsors, Kaiser Permanente of the Mid-Atlantic, as well as Zoom. Thank you to our attendees for joining us and participating in the polls. We know we weren't able to get to every single question on the Q&A, but we will be following up with some more information and resources. Look out for a white paper coming from our from the PCC. We will be also sending out a recording of this panel if you missed it as well. And those questions that we maybe weren't able to get to, we can send them out to our wonderful panelists, and they can also, they'll be able to offer a little bit more insight after the fact as well. So thank you again to everyone for joining the Primary Care Coalition's convening on telehealth. Make sure to sign up for our monthly newsletter if you haven't yet already, to stay informed about the latest developments regarding telehealth in Montgomery County and beyond.